Good afternoon, everyone. My name is Tambi Swiney. I'm the Spiritual Wellness Coordinator at the Next Door. I am grateful that all of you chose to take time out of your busy schedules to be with us today for this important discussion of race and addiction. Before we get into our questions and answers, I encourage you all to make sure that you are muted. And also, those of you who are participating, I would love for you to enter your name and your organization name in the chat box so that we can see what groups are represented today. This panel discussion grew out of conversations that bubbled up naturally here at the Next Door in the wake of the murder of George Floyd. Several of my colleagues and I began to talk about what it would look like for the Next Door to move beyond being an organization that does not discriminate, which by law we are required to be as a licensed addiction treatment center. But what would it look like for us to be actively anti-racist? And we began to talk about different issues and ask questions like, why don't we see more clients of color at the Next Door? How does the trauma of racism, compound the trauma that our clients who have already been dealing with trauma through addiction and mental health issues, how does all that come together and how do we deal with that as a treatment center? So we realized we needed help. We needed to hear from people who know more than we know, and that is why we decided to have this panel discussion. I am deeply grateful for our 4 panelists who have chosen to join us today and are going to give us some insight into these issues and more. I'm going to briefly introduce each one of them and ask each one to tell us why, in their opinion, is this discussion about race and addiction important at this time. So first, I'm going to welcome Ms. Keita Haynes. She is the legal advisor at Free Hearts, which is a nonprofit organization led by formerly incarcerated women that provides support, education, and advocacy for families impacted by incarceration and deportation. Prior to working for Free Hearts, Ms. Haynes served our community for 6.5 years as an assistant public defender at the Metro Nashville Public Defender's Office. As senior legal counsel, Ms. Haynes brings a unique perspective to her work in the criminal justice system because she spent almost 4 years in federal prison for her alleged involvement in a drug distribution ring, a crime that she did not commit. Ms. Haynes, welcome. Thank you for joining us, and tell us why you believe this panel discussion is important at this time.
Okay, sorry, I was still muted. First of all, good afternoon, everyone. And thank you, Next Door, for putting on this panel. This is a very timely panel right here in the moment that we find ourselves in. And it's great that we're having these conversations. And so I would say that the reason why it's important that we talk about race when it comes to addiction is because we're all across this country, people are out in the streets and people are, protesting, and we are hearing the likes of Black Lives Matters. And I think it's important that we understand that, Black Lives Matters doesn't begin and end with police accountability. Black Lives Matter, we need to make sure that Black lives is mattering across every single spectrum in order for us to really experience the healing, justice, and liberation that our communities are calling for. And so, that's why I think that it is important, that we talk about, race when it comes to addiction, because we know that, if it's court ordered, we know that Black, brown, and low income communities are, disproportionately impacted when it comes to the criminal justice system. And so what we're seeing in the criminal justice system is that we're seeing that addiction is being criminalized. And so, so the broader aspect of that is that because a lot of people don't have healthcare that will cover types of addiction treatment that they would need. And so they're ending up coming into the criminal justice system. Addiction is being criminalized, and they're leaving out of the criminal justice system worse than what they were to begin with. And so, I think that is something that, also needs to be looked at, is, why we are criminalizing addiction the same way that we're having conversations about, we shouldn't be criminalizing mental health. We should not be criminalizing addiction as well too. And so again, like I said, this is the broader aspect, because, generally it's white people that do have the adequate health care in order to go and to get the addiction treatment that they need. And it's usually people that are Black, brown, and from low income communities that don't. And so, there are the disparities there. And the broader thing is that this is the disparity when it comes to healthcare as well too, because if you don't have, the type of healthcare that you need in order to get adequate treatment, you may be forced to get some other treatment that may not be as effective if you do have, healthcare, and you can go and get that. And so we saw that a lot, in the public defender's office, because a lot of our clients did not have health insurance. I personally went with a client that was, he had an opioid addiction and didn't have health insurance, and personally took him, to get some treatment. And we literally went to a couple of different treatment facilities, ended up going to an emergency room. And because he put me down as like his contact person, they were calling me for a bill for him, all because he didn't have health insurance and because he was there, in the hospital trying to get off of heroin. So this is a very timely conversation, and I appreciate the Next Door having this conversation, and I appreciate you asking me to be a part of it. So thank you.
Thank you. Next, I would like to introduce Dr. Monte Burks. He is the Director of Faith-Based Initiatives for the Tennessee Department of Mental Health and Substance Abuse Services. In this role, Dr. Burks engages and connects Tennessee's faith communities to the behavioral health system, and he has the goal of expanding addiction and mental health support services across our state. Dr. Burks is a certified peer recovery specialist with more than 20 years experience working with the criminal justice system, including serving as an adjunct criminal justice professor at Motlow State Community College and Tennessee State University. Dr. Burks, welcome, and tell us why, in your opinion, is this an important conversation for us to be having?
Well, first, I want to say thank you to the Next Door, and thank you to my esteemed panelists. I've done a lot of work with the Next Door, and I'm familiar with some of my panelists, including Dr. Graves. One of my colleagues told me to tell you hello, that you had actually delivered his son at some point. So he saw your name on the panel on something that I posted on social media. But that was really cool. Segue in our conversation. I get to be on a panel with this young lady and talk about what we've got going on. So he said to tell you hello, and I'll inbox you and tell you who that is later. But I'm so thankful to be here. I'm a person that's in long-term recovery from substance abuse and a mental health diagnosis. I'm a biracial man. My mother's an African-American woman. My father's Caucasian. I grew up in the Black church and the Black community. I understand that there are sometimes miscommunications on access points to get people to resources. And I know that, right now, this conversation is important because a lot of our communities don't know what the resources are. They don't know how to channel resources. They don't know how to access resources. So sometimes there are communication barriers and translation barriers between services. And if we can really put our heads together and be strategic on how we communicate with our communities, we can help more people access treatment services that do exist. We need more champions like Ms. Haynes that are willing to walk with someone. But what about when she walks with someone and then the resource tree runs out? She gets to the end of the road and she doesn't know of any other resources, or her client doesn't know, or even the hospital that she goes to, they don't know what to do next. I'm sorry that someone left you with a bill for trying to help someone save their life. But that's what these conversations need to be had for, because we have some impactful pieces that have happened to our communities due to lack of knowledge of resources in those communities. My job as the faith-based director for my department is to reach out to our congregations, our churches, our synagogues, our mosques, and I reach out to people of all different traditions, all different backgrounds, and I hear the same conversations over in their communities, and it's the same conversation we're having now. What do we do when a person comes to us and they need help and they don't have any money, they don't have access to resources, they don't have insurance? I'm going to share some information today. I have a group of people that are in recovery from substance abuse, and they're resilient and they're working through a mental health diagnosis and or crisis. They're very active in the community, and they're also a resource for the community. And they're very strategic and logistic when it comes to working and helping people, especially in the inner city, because sometimes we don't know that when a person reaches out to us from North Nashville, East Nashville, South Nashville, West Nashville, inner city, sometimes we need to find a way to get them out of the city so they can find healing, so they can come back to the city. So sometimes our treatment options may be narrow inside of the metropolitan area, but and there's 94 other counties in Tennessee that may have an option for them if we know what those options are. I work with a broad coalition of African-American pastors to concentrate on mental health issues and conversations in the church. And that, again, there's an initiative out of Memphis, Dr. Jackson, No Whispers in the Church. And what that initiative is geared toward African-American churches and having the conversation around mental health in the pews of our sanctuaries, and how not actually having a conversation has led to people not asking the right questions because of the stigma associated with coming forward and saying, hey, I have a mental health concern, or hey, I suffer from substance use disorder. I spent 271 days in treatment. And that was because the criminal justice process introduced me to a treatment program, or I had to go somewhere else for a little while. I was given that opportunity through criminal justice intervention. So everybody doesn't have that opportunity. And Keita expressed that fairly when she was talking. Everybody doesn't have the same opportunities. So how do we get that to the forefront? How do we change that conversation? And I hope we're able to cover that today. I think we need more champions in the African-American community, more champions in the African-American church. Listen, I grew up Kojic. My mother's a missionary evangelist. She plays the piano. I went to church 19 times a week, and we never once talked about addiction or mental health, not one time growing up. But the church is actually how I found my freedom from addiction. So there's a very unique relationship there, and I'll go into that later after our esteemed panelists share their information.
All right. Thank you very much, Dr. Burks. Next, I would like to introduce Ms. Sierah Campbell. She is a therapist at Connect Counseling Center in Clarksville. She's a nationally certified counselor and a licensed professional counselor, mental health service provider. And she is dedicated to clinical leadership, program development, and mental health treatment advocacy. Ms. Campbell has a passion for working with adults who are experiencing relationship issues, grief, substance abuse, post-traumatic stress disorder, anxiety, and depression. As an advocate for underserved populations, she often speaks on multicultural awareness and counseling competency, and she also teaches at Austin Peay State University. Ms. Campbell, thank you for joining us today. Why is this an important conversation from your perspective?
Well, first, thanks again for inviting me to speak on this topic. It's nice to see some of you again. Obviously, I'm no stranger to the Next Door since I used to work there with you guys. So thank you for that. I think this is a very important topic. As we know, addiction impacts people of varied racial, ethnic, and socioeconomic background. As we know, addiction is typically a maladaptive coping skill and may be an outlet in an attempt to temporarily relieve stress, which we know can then lead to physiological dependence on substance or substances. Due to an increase in environmental stressors like national crises of COVID and social injustice, and let's be honest, our nation is no stranger to social injustice, it's definitely impacting citizens. More specifically, the impact on African Americans living in a society full of members publicly taking a stance for equality tells us the additional progress we need to make that many mistakenly believe was a problem of the past. So since environmental stressors is a precipitating factor of substance abuse, I'd say that this is an important topic to discuss. It is vital clinicians recognize trauma is experienced when a minority sees someone in their likeness treated inhumanely. As we know, the science of mental health indicates environmental stressors increase mental health symptoms, which I can confirm is happening as therapists respond to reports of heightened hypervigilance due to the current state of our nation. So environmental stressors of today can impact maladaptive coping skills, and substance abuse may be that maladaptive coping skill. So this is definitely a relevant topic to discuss.
All right, thank you very much. And then our fourth panelist, Dr. Cornelia Graves, is the medical director for Tennessee Maternal Fetal Medicine and the medical director for Perinatal Services at St. Thomas Health Systems. She's also a professor at the University of Tennessee and serves as clinical and adjunct professor for Vanderbilt and for Meharry Medical College, respectively. She has been involved in research and has served as an investigator on studies involving asthma, HIV, diabetes, drug addiction during pregnancy. She is the co-founder of the Collaborative Perinatal Cardiac Center, which is the first program in the nation that addresses maternal heart care from preconception through postpartum care. Dr. Graves, thank you for joining us. And why do you see this as a timely conversation? We need you to unmute yourself, Dr. Graves.
Get so used to. So the first thing I think, let me, before I even get started, because, you know, as soon as I get started, my phone is going to ring. So let me take care of that right now. Hold up just a second. The first thing I think we have to remember is that when we talk about health disparities, we often talk about health disparities in terms of COVID or things of that nature. But one of the biggest health disparities in this country actually is in women's and pregnancy in particular. What we know is that Black women, women are more likely to die during pregnancy than any other racial or ethnic group. And if you happen to be a woman over 40 in this country, your risk of dying is about the same as it would be in Ghana, West Africa. So, you know, when we talk about disparities and when we're looking at addiction and substance use, as a maternal fetal medicine specialist, I'm also looking at it as a larger backdrop of maternal mortality. One of the things I've been really active in the state of Tennessee is the Maternal Mortality Review Committee. As you know, for many years we tried to get one. I finally was able to petition Representative Harold Love, who was one of the champions for us, to get this pushed through. And in our third year, what we know in the state of Tennessee is that our pregnancy-associated deaths are associated with addiction and substance misuse. Some of those are overdose. Some of those are cardiac, because we do know when women shoot up heroin or do IV drugs, they are more likely to get endocarditis. Even if subclinical, it goes undiagnosed. The stress of pregnancy then causes the cardiac system to unmask these things. And so many of these women are dying before their child is 1 year of age, because pregnancy-associated deaths are in the next 365 days after you have a baby. And so we really need to look in this state how we can do better in this particular population. Secondly, you know, we talked about insurance. Well, the good thing about pregnancy is in the state of Tennessee, everybody has insurance. But one of the things that I've been fighting, and, you know, I'm sure that the TennCare people are tired of me, is the separate but unequal access that people have. For example, if I write a prescription for someone with private insurance, it does not matter how much I write for. For buprenorphine, I can write all day. If I need to change the prescription, I don't have to I don't have to get a new pre-certification. I just write. And so the patient, then I'm able to titrate that to the patient and the patient's needs. Whereas when you have TennCare, only I can write for the prescription. So like I was lecturing in Hawaii, and so somebody had to call me because my patient lost her prescription. And so no one else, even with an X license, could write for it, because at TennCare, only the provider writing for that person can write for the medication, which then inconveniences the patient and the provider should the provider have to go out of town, or should the patient have other issues. In the office, also, the number of pre-certifications I have to get for a patient is ridiculous. I have to almost hire a whole nother person to do pre-certification. So even though these patients may have insurance, they're still not treated equally. Often my patients tell me when they go to pharmacies, the pharmacy treats them as if they're criminals instead of people who are trying to be in recovery. The other thing is, often, even in pregnancy, we have limited access to mental health resources. I hate to speak in nepotism, but my son is a mental health therapist, and he recently got that was certified by TennCare. So I have been able to use him as a source, because many of our patients, a lot of mental health specialists do not take TennCare. And so that becomes an issue for patients. And then how DCS often treats patients is an issue as well. If you happen to be Caucasian with private insurance, you have a substance misuse disorder. and we're going to help you through that, and we're going to, you know, do all these things to get you better. When you happen to be poor, or if you happen to be a black or brown color, then you're addicted, you're a bad mother, and we're going to show you that you're a bad mother by taking your children and not offering you the resources we could offer you in order for you to have better recovery. So I think that this is exceptionally the right time for us to talk about this, because as we talk about health disparities in a broader text, we really need to bring forth addiction. I always point out how when crack cocaine was available in pregnancy, we called them crack babies. And these women were criminalized, they were jailed. But now, you know, if it's like I said, if it's a Caucasian or majority, you know, we want to have a much more kinder, gentler approach where we support patients. Well, that kinder, gentler approach should be across the spectrum and across all drugs, because I always tell people that addiction is, you know, whatever you're addicted to is your substance. Number one, I always tell my patients, don't worry, everybody has an addiction. You know, I was doing mission work in Guyana, and I left the mission site looking for a Diet Coke. That would be an addiction. So therefore, everybody has an addiction, you know, even though we don't like to admit it sometimes, but also that there are better ways of coping with our addictions that will allow them to have healthy babies and healthy families. Because if we do not support our families, it doesn't matter what else we do, because then we continue a cycle of adverse childhood events. Then we have hurt adults who then produce hurt children. And so we continue the same cycle over and over and over again. So I'm hoping as we talk today, we'll address more of those issues, especially from a women's health standpoint, because as the woman goes, so does the family.
Yes, thank you so much. Well, in case you haven't noticed yet, in the chat box, my colleague Morgan has been putting links to all the organizations that our panelists are involved with. So that'll be an easy way for you to know how to keep up with them and learn more about their work. If you joined us late, we're asking everyone to please put their name and their organization in the chat box so that we can see who all has joined the conversation. All right, well, we've already touched on a number of issues just in the introduction, so let's dig a little bit deeper. I've asked Ms. Haynes to address this first question, but then it will be open for other panelists to jump in. So the opioid crisis has been called one of the largest public health emergencies of the past decade, and the federal government has diverted billions of dollars into treatment to address the crisis. But we contrast that with the 1980s, when crack cocaine was ravaging, in particular, the Black community. And at that point, the federal government declared a war on drugs. So one of the questions that has bubbled up here at the next door is, what are the long-term ramifications of how the government has handled these two crises differently? And do you have any personal anecdotes related to unequal treatment?
Yes, so I think Dr. Graves actually touched on that some as well too when she was speaking. But, you know, we know that, you know, this war on drugs was, you know, declared back in about like the early 80s, and it really has been a primary contributor to the enormous growth, you know, of our prison population here in the United States, which, you know, currently is about 2.2 million people. And the United States has the highest incarceration rate in the entire world. And so a lot of people, you know, that were, you know, arrested and caught up in this war on drugs actually were people that had drug problem. And so the response to the drug problem, you know, were national policies that emphasize punishment over treatment. And emphasizing this punishment over treatment has disproportionately impacted Black and brown and low income communities. And it wasn't until we started to see the complexion of the people that were actually addicted to drugs change that we decided that we wanted to actually change I approached to drug addiction. And it was when, we started to see more white people being addicted to drugs, particularly, during the opioid crisis. And more suburban people being addicted to drugs. And so the people that were being addicted to drugs and was actually being brought into the criminal justice system, it changed. And so then we decided, hey, you know what, maybe we need to change our perspective on how it is that we are dealing with drug abuse. And so then it was just like, we need to be more compassionate, more have more health-based interventions instead of criminalizing drug addiction. And so, so that's where we are right now. And, working as a public defender, I made sure that I brought that up, when I had a Black client that had been addicted to crack cocaine for years. And there would be instances when, DAs would just want to really and truly give them a sentence and just, and punish them. And, and I'm just like, oh, is treatment not an option? And then it was just like, oh, well, do they want treatment? So, we're looking at, whether Black people want treatment differently than white people, because we just automatically assume that because it's a white person that they want treatment, but Black people that's addicted to crack, it's just like, oh, well, do they really want it? Are they really going to do it? And so I think that, therein lies, the disparity as well too, with how we treat people and how we look at the differences in races when it comes to, who is going to be more susceptible to treatment as well too. And, and so those were, several of the issues, but then also too, there are issues when it comes to the actual treatment of, Black and brown people as well too. And I think, Dr. Campbell, she alluded to it as well too, when she was talking about, traumatic experiences that people have. And so I think that when we are looking at treatment, I think that, it's important that we are talking about, the entire person, the whole person, and not just a cookie cutter method of, of a treatment plan. I think, that's one of the things that's really important. And so when, we are talking about, treatment with Black people, there are so many different traumatic experiences that Black people have experienced simply because of the color of their skin. The color of their skin is criminalized. And so that's a traumatic experience all within itself. And then, you turn on, you flip onto social media, on Twitter, Facebook, Instagram, and, you're seeing people that look like you, people that look like your brother, that look like your cousins, your dads, being, killed by police, experiencing police brutality. While it may not be you that is physically experiencing that, that's a traumatic situation that you are, dealing with. And then when you look at, our environments and stuff, where a lot of Black and brown and low income people are living at, that's a traumatic situation all within itself, within their communities, because the communities are also over policed as well too. And then, we have an issue of, the lack of resources, the lack of healthcare, lack of jobs, our education system is underfunded. And so it is all of those things when we are talking about, what is it that we can do when it comes to treatment and to make a person whole. And so I think that, when we are dealing, particularly with Black people, we have to recognize that there's a different traumatic situation that Black people have been experiencing and have experienced from the time that they set foot on the soil in this country here. And so, we cannot, just ignore that when it comes to treatment of Black and brown people. We can't ignore the fact that their neighborhoods are over policed. We can't ignore that. We cannot ignore the fact that we are criminalized simply because the color of our skin. And so, it requires you to go above and beyond. And so, a lot of times, you experience where people don't want to deal with it. People are, Black people are labeled difficult when it comes to treatment, treatment resistant, those types of things. And so, particularly in the court system, when treatment is court ordered, and so we find where Black people are kicked out of treatment programs because of this. As I was sharing before we came on, I had a particular client. She was a female client, young Black female, had a lot of traumatic experiences, in her life. And she was labeled difficult, and she was labeled treatment resistant. Even in some of the better treatment programs in the, the courthouse, in the criminal justice system, Not once in my 6.5 years working at the public defender's office did I ever have a white person that was ever labeled treatment resistant. But I can tell you that I had several of my Black clients that were labeled treatment resistant. And so again, therein lies a disparity, you know, in the treatment. And so, you know, this is so much bigger, because I think when we are talking about our treatment providers, you know, we need to address the different, you know, biases that they have when it comes to treatment, and when it comes to whether Black people are actually, you know, going to, you know, embrace treatment, and, you know, and those types of things. And so, you know, so I think, you know, we really have to look at that, because even though we're in this era where we are wanting to be more compassionate when it comes to drug addiction and drug abuse, we're only more compassionate when it comes to white people. We are still not compassionate when it comes to Black, you know, and that's definitely something that we need to address.
Thank you very much. Do any of the other panelists want to add to what Ms. Haynes has said?
I wanted to go ahead, Sierah.
No, go ahead. It's fine.
No, well, I was just going to share that, and Keita hit it on the head. You know, vicarious trauma, VT, is something that's passed down from generation to generation. So what happens is when someone did not make it in treatment, when someone was given a bad deal through the criminal justice system, the stories that they go and tell their family members, their friends, and people in their community are stuff that makes them not trust the system at all. So when they pass down VT, it causes PTSD, which causes people to not want to access the system the same. This is like a hamster wheel turning of trying to figure out how to implement services and practices in communities where people have looked at the system itself as something that doesn't serve them or doesn't benefit them, or they don't have equal or fair access to those communities. And it's something in the field that I work in recovery. The recovery community is large. Recovery doesn't look a certain way. It doesn't smell a certain way. Just like you said earlier, everybody's in recovery from something. Every single person on this panel, everybody in America that's above 2 years old is in recovery from something. I mean that with all due respect, not necessarily substance abuse or a mental health issue, but people have had a hurt, habit, or hang-up that they needed help to get over. But if you have a bad experience trying to access help, you're not going to go to the same source to ask for help again. You're going to go somewhere else. And if people won't fellowship with you or meet and connect you where you're at, you're probably going to go back to the streets that you've been running from. So that's where and this is just me, in my opinion, my professional opinion, my acumen, is we need to identify more champions in our community to go back out and tell their story. Because there are people on this panel that I see right now that have survived every single thing that said they wouldn't make it. They are the survivor that can go back and tell a good story and then pull champions out so they can help them navigate the system. I worked in the criminal justice system most of my professional career as a job placement specialist. I've seen barriers and biases across all different fields of play. Some exist, and some people assume that they still exist. And sometimes people, just because of the way the situation looks, they will not even choose to access services. That's vicarious trauma. They are already traumatized. That is what vicarious trauma looks like. So how do we pull champions out of communities? How do we reach out to people who have survived addiction, people who have survived the criminal justice system, which I respect greatly, people who have been through the system and can come out and tell people what the system actually looks like. It is a place that you don't want to go. But if you do happen to get caught up in the system, here's how you navigate life post-incarceration. How do we pull these champions? How do we identify these champions? My thing is, or my question is, or my concept is, we have to do it. Us, right here, this group. Every time we pass the buck to somebody else, we assume they're going to pick the buck up. But what if they don't? What if they don't pick the buck up? I am a biracial man. I grew up in an African-American community. I have relatives of mine who have never accessed the system nor chosen to because they don't understand how the system works, because they don't trust the system. It doesn't necessarily mean, but they'll reach out to me, and then I have a unique opportunity to help them navigate the system. So again, I'm thankful for you guys' comments and questions. I really look forward to working with you all on a professional capacity after this conversation is over with, because maybe sometimes there's somewhere the change has to start, and maybe it starts right here with us today.
I completely agree with what's been said, to say the least. I think too, Ms. Haynes touched on the dramatic increase in incarceration rates for African Americans during that time frame in the 80s. And I think the comparison of cocaine usage within the African American community in the 80s versus the way substance abuse is viewed and treated now is in large part impacted by our nation's view of the user during that time frame. The user in this scenario being African Americans, which led to what was already mentioned, the punitive consequences rather than rehabilitative. but there's actually an article that I came across. It's titled, "Is the Prescription Opiate Epidemic a White Problem?" And it's by Dr. Helena Hansen and Dr. Julie Netherland. This article was actually published in 2016. It mentions in the United States, where insurance coverage and access to physicians are racially stratified, opiate prescriptions disproportionately went to white patients, whereas non-white patients with access to a physician were less likely to be prescribed opiates, which increased racial differences in opiate use. So a part of this is impacted by access as well. This is where the difference in treatment is apparent. The authors go on to say, when non-medical opiate use increased in white communities, rather than arresting consumers, regulators mandated physicians to use prescription drug monitoring programs. So here comes the naloxone, or known as Narcan, used as an antidote to opiate overdose, and the naltrexone for relapse prevention to treat those in recovery from opiate usage. So at that point, policymakers were calling for reduced sentencing for nonviolent illicit drug offenses and the expansion of access to addiction treatment. So the stark contrast in how these situations were handled is clearly evident.
Thank you all for your perspective on that question. Our next question, I'm going to let Dr. Burks take the first stab at it. And you've already kind of addressed this in some of your other remarks, but why don't we see more people of color in treatment programs? What are the factors involved? How does racism play into access?
Well, you know, Keita, Sierra, and Dr. Graves we've all hit on this question indirect. I guess we accidentally segued, but it wasn't accidentally. You put the right people on the panel. We're going to answer questions. We're going to pull some dirty conversations out. But one of the things, so I'm going to go from the perspective of a person in recovery and a faith-based director, and I'm going to let some of my clinical professionals add on to this as well. Growing up in our communities, the general conversation around addiction and mental health issues were, one, if you said you had a mental health issue or a concern, somebody told you were crazy. The minute somebody told you were crazy is the minute you didn't want to go access resources. You would rather have a secret that would keep you sick, as opposed to going and telling somebody that you have an issue. Now, I'm talking about cultural issues are a barrier to accessing services, because we don't sometimes as professionals have the right conversation. I've been a criminal justice professor for some time, and I've recruited from different areas across the state, specifically African Americans, to go through the criminal justice school, go to criminal justice school to become police officers, to work in the court system. And some of the conversations we've even had around, hey, somebody in my family has a substance use disorder. Somebody suffers from addiction. I stay away from the word addict. I don't like to call somebody an addict. That's just the way I talk. I'm a person in long-term recovery. I'm not going to do that. I think that we've evolved enough as human beings to not continue to demonize people by words. Some people may still call themselves an addict. I'm not going to do that in my conversation. I'm going to say a person who has substance use disorder. I think the evolution of the recovery community is why we do some of that now, because we saw how we treated people in the 1980s during the crack epidemic. We called people crack addicts, crackheads, crack babies. How stigmatizing is that? And how do you think those people are going to come to you and ask you for help when they need help? Absolutely not. So culturally, I think that sometimes the conversations are a barrier to getting people to access treatment. I work for the state of Tennessee. I work with a treatment and recovery director in my department. We make sure that all of our treatment providers provide equal access, regardless of a person's ethnic background, sexual orientation, socioeconomic status. And we encourage every single one of our providers that we work with to have ongoing conversations and to hire and recruit people from diverse communities so they can be culturally competent to what treatment and addiction look like. The minute our professional programs try to tell you, anybody across any realm, that something looks a certain way when you're dealing with addiction and mental health, they're wrong. They've lied to themselves, because it doesn't look a certain way. Nobody would know that 20 years ago I had a mental health diagnosis. I wouldn't have known I had a mental health diagnosis unless I went and had a substance use assessment, and then I found out I suffered from clinical depression. What would be? As an African-American man, the last place I went was my African-American community and talked to my uncles and my cousins and my granddaddy and said, hey, I was diagnosed with a mental health issue. The first thing I did is I ran away from them, back out into the streets. So those one of the barriers. From a professional standpoint, I'm going to kick that from a clinical standpoint. I'm going to connect that over to Dr. Graves, because I think Dr. Graves may be able to answer some questions from a clinical side, from the hospital side.
So I think that one of the reasons that people don't access care is because it's not always available. and we were talking about, the whole telehealth thing and how we're not going to go back. Many people who are of lower socioeconomic status, or which includes many of our rural and Black and brown people, work jobs. And they work jobs from 8 to 5 o'clock, just like I have a medical office that is open from 8 to 5 o'clock. They also do not have benefits. So therefore, and many times they do not know how to even navigate the system to get off from their job. So therefore, if you really think about it and you talk about it in those terms, and then we say, oh, well, you need to show up for your appointment. And then when they don't show up for their appointment, we label them as, quote, non-compliant. And so then, of course, when they do show up, or if they're late, then we have an attitude about why they're late for their healthcare appointment. One of my exercises is actually to have my residents ride the bus from North Nashville and get to the other side of town, because in Nashville the bus has to change because back in the day people of color couldn't come to the other side of town without permission. So therefore, and I give them like a backpack and some stuff to keep up with, so like they have a baby and stuff carried, and to make them understand that many times people aren't actually, quote, non-compliant. What they are is they just can't comply because they don't have the resources or to do so. We've seen this in COVID for sure. Most of the people who are affected by COVID have been people who work jobs in which they are called essential employees. They have very little insurance. They cannot take off or they will lose their job. Well, how do you expect anyone who has a substance use disorder, who's functioning at all, or who goes from job to job to job trying to survive, access the healthcare system? Secondly, when they come, we're not always that welcoming. As I said, we tend to have judgments about who they are, what they are, and what their lives are before they even can hit the door. Because when I see a patient, I already have on my little diagnosis why they're here. And so, and the words that we put in the diagnosis tell me everything I need to know about what I'm about to deal with. So I have one the other day, it says type 1 diabetes, non-compliant. I already know that patient, that referring provider is exasperated, and that's why he's seeing the patient, and the word non-compliance let me know that she's not doing what we, quote, would like them to do. And I think the last thing is a lack of trust. We don't trust the healthcare system. If you talk to Black women and you do there's this whole thing about women delivering at home, Black women delivering at home, because they don't trust us. They do not trust us to do work in their best interest. They are afraid that we might enter them into some crazy study that they have that they don't have any control over, because they don't realize that those days are gone. But the healthcare system, which was built on systemic racism, used to tie Black women's tubes without their knowledge. So why would you trust a system that which your mother and your grandmother has told you has not been kind to them? Like you said, the trauma of coming. So I think those are some of the reasons people do not come for help. And last but not least, in fact, I had this situation just the other day with a husband who was somewhat irate. And I said to my staff, I said, you have to remember that anger is fear turned outward. So often, when we come, somebody else may express fear, we express anger because we've been told we cannot express fear. So when we come and we're angry, then that's when people decide that as Keita said, that we're treatment intolerant. We can't do it because the first time we blow up and express our fear, the health community says bye. We don't have to put up with that without really examining why this person is angry, why they're scared, why they feel like the healthcare system is not working for them. And those are many of the reasons that people do not access our healthcare system.
I want to follow up with Dr. Graves with one more thing. She brought something that I didn't say. Providers should look at culturally competent navigators for their systems. So if you want more people to access your system, hire people from that community to be the conduit of information. Again, people that understand the trauma, intersectionality of a community, how gender and race play a specific role, having people that have that cultural competency in them through their own experience, they'll be able to hear a different song than some of the practitioners. They'll also be able to understand that while something may not have happened to me, it may have happened to you. So I at least respect you enough to give you the space to articulate that and then try to find the appropriate resource to connect you to.
Thank you. Ms. Campbell, we've already touched on trauma-informed care and how the trauma of racism, there's interplay with the other traumatic experiences that many of our clients have faced with their substance abuse disorder and their mental health issues. Can you say a little bit more about trauma-informed care and what treatment centers can do better to deal with these layers of trauma?
Sure. So yes, you're right. It does correlate kind of with what I mentioned in question 1. So again, I think it's vital clinicians recognize trauma is experienced when a minority sees someone in their likeness treated inhumanely. Racism-related experiences can include hate crimes, physical assault, racial microaggressions or stubble, yet pervasive acts of racism. These can be like brief remarks, vague insults, or even nonverbal exchanges. In the clinical setting, I'd like to say don't shy away from these conversations if said conversations are initiated by the client. Many scholarly articles reference many ethnic and racial groups experience higher rates of post-traumatic stress disorder. In many studies, the psychological impact of racism on African Americans correlates with a high number of PTSD-related symptoms. Now, that PTSD may be undiagnosed in many due to a lack of receiving treatment. Again, it can be traumatizing to see any human being of any race treated inhumanely. However, seeing someone in your likeness has a much different impact on that individual, which kind of correlates with what Ms. Keita was indicating earlier. I think right now there's definitely a ripple effect happening in our nation. The current social justice advocacy is leading to various cases of unsolved deaths of African Americans being reopened. For those African American families, this is reopening wounds during their pursuit of justice they were originally denied. This is also reopening wounds of people within the African American community because it's a reiteration of the unequal treatment we endured in the past and the unequal treatment we may be subject to endure in the present. So as we know, there's a strong correlation between trauma and addiction. So in addiction treatment, the underlying issue that led to the substance usage must be treated for relapse prevention. There's so much to say on this, including other factors. However, I definitely want to give other people on the panel an option or at least a space to speak to this because this is so multifaceted.
I'll say something and then pass it on. Thank you for sharing that. Thank you for talking about trauma-informed. A lot of our community doesn't understand how to speak to people in person-first language, not understanding that they can re-traumatize a person in just how they talk to them, just how they talk to them. So having the right intake coordinators, the right people to give assessments, the right attorneys, the right lawyers that know how to talk to a client, to motivationally interview them, to give them the true information. I know, Keita, I'm sure you in your work that you ran into clients that were absolutely scared of you just because you were a lawyer. They didn't tell you the full truth of their situation, not because they didn't trust you, because they didn't trust the system. And you know, these are things we run into as professionals, but we as professionals also have to understand that we need to be trauma informed. And so does every single person that we come into contact with that has a position over someone else's life and someone's access to a resource. You know, I've worked with the Next Door for years, and I love that your intake coordinators are mostly people with lived experience. You can tell when you talk to them, when I come and meet them, that they've been through something. So they understand what a fire smells like, so they can smell burned ashes. So when a person comes in, they will be good to them and love them and meet them where they are, but also hold them accountable enough so they can get them into the program. And I think we need, you know, I think that we need to, and I hate to speak in absolutes, but that's a have to, need to, must. Someone with lived experience that understands trauma-informed care and person-first language as the original access point to get people to services. I'm not a doctor, I don't have an MD, but I have enough lived experience that I can probably guide a person to talk to the right people to get them to Dr. Graves, just through lived experience and respect for other people's humanity.
Dr. Graves, we've already talked a little bit about the stigma that exists. It's associated with mental health and addiction in the Black community. I'd like for you to say more about that. And particularly in relation to pregnant women. You know that we serve pregnant clients here at the Next Door. And so I'm interested in understanding more about those barriers.
Well, I think that the stigma of substance use, period, is a problem in pregnancy. Whether you be Black, white, but because what people are first going to say is they're going to say, how could you do anything to hurt your baby? Now, they're not thinking about you as the person. They're looking at you. I always call it, sometimes we treat women in this country like incubators. You know, that we're just the wrapping around a baby. And I think one of the things that is most interesting to me is that 2 of the most lethal drugs for pregnancy, we consider to be socially acceptable. So it's not addiction. It is not you having an addiction or substance use. It is what you decide to use. For example, you know, when Tennessee decided to have that insane law where they would put women in jail, remember that one? And I worked really closely with one of my friends at the governor's office to say, hey, this needs to sunset, because what I was seeing is that my opiate addicted women were, you know, who had opiate misuse disorder, decided just to use alcohol instead. And so when I went to my, you know, one of the legislators and said, do you understand what the impact of this law is? He said, okay, well, what's the big deal about them using alcohol? And I said, well, you know, what you're really worried about is paying for a baby for NAS, because really that's what they're worried about. You know, I said, but let me just tell you, we don't even know if NAS has a long-term impact on babies. Alcohol misuse, you'll be paying for that baby for the rest of its life. And they looked at me like I had 5 heads, and they said, oh my God, I had no idea. The same thing with tobacco use. I said, if I could just list off all the things of tobacco use: preterm labor, preterm rupture of the membranes, the baby doesn't grow well, sudden infant death syndrome, increased risk of asthma, increased risk that your placenta can come off prematurely, which can be life-threatening for you and the baby. Now, if that were marijuana or some other drug, we'd be out in the streets with a picket sign. But because it's a legal drug that we can access over the counter, we think nothing of the fact that the mother comes in smoking 2 packs a day, but uses marijuana every week. So I think that we have to not only, when you talk about, you know, what is it, the stigma, we have to change not just the stigma of having a misuse disorder, but the stigma of what you use. You know, that's why I said at the beginning, everybody has some type of misuse disorder. I love Starbucks because, you know, people are sitting live for Starbucks. If I want Starbucks, I have to leave the house 15 minutes early. You know, I know, and when you talk about, you know, a DSM-3 diagnosis of time mismanagement and, you know, will defer other things. I mean, if you think about it that way, that is very much a part of some type of misuse disorder. And the fact you'll pay $8 for it too. And so therefore you have to think in those terms. I think particularly, however, in the Black community, it was interesting when people were saying that their mother was a church musician and missionary. My father was a minister. My mother was a pianist and a Sunday school superintendent. When I was younger, not only did I play the piano, but I sang. And so when my father went to preach, anybody who grew up in the Black church knows I was the A and B selection. You know, I would get up and sing, my father would preach. And so what happens is, since most of us are steeped in the religious community, one of the things we say in our religious community is that God is a mind regulator. And since God is a mind regulator, then if my mind is not regulated, why is God regulating, you know, Monty's mind, but he's not regulating my mind? Is there something wrong with me that God has not fixed me? And so we see it almost as a moral failing more than an issue of biology. And so when you see something as a moral failing and not an issue of biology, it becomes even more harder for you to understand that in the context. You know, my son did some work with our youth department at one of our young people's meetings. And one of the things he said, it's okay to love Jesus and have a therapist too. Because in our community, it was like, you can either love Jesus or you can have a therapist, but you cannot have both. And so we have to talk about that in those terms. And then often there's a lot of silence in our community. You know, there's the silence of abuse that we don't speak of. There's the silence of gender identity. I always tell people in the church, you know, where everybody goes, if a guy can play and sing and do the types of things we need for him to make the choir well, he's quite accepted. However, if he comes out and tells his family that he has that he doesn't like women, then that's a whole nother issue. And we're going to pray over you, and we're going to find you a good woman because you're just confused, and we're going to make sure that God, you know, works on this. So we have to, if we're going to reach the African American community, we have to reach it in the, we must reach it through the church and through faith-based initiatives. Because it is hard for us to really receive that mental health is not some type of moral failing. And if we think it's a moral failing, then it doesn't matter what we do from a healthcare standpoint until we make people understand this has nothing to do with you personally. This has nothing to do with you spiritually. This has everything to do with you biologically. And so those are the things that we really must bring forth if we're going to change how the disparities are in our community and in women, because I think women also have that same thought process. You know, we're supposed to be all things to all people at all times. And when we are not, then that is our failing. Not the fact that, you know, in fact, I remember when I came home when someone, you know, they were like, well, blah, blah, you know, what's for dinner? Well, you know, everybody in this house is, you know, is grown. We're having sandwiches, make you one. And so, you know, but, you know, then everybody was looking as if I was the failure because somehow it was my job to plan every single night for people to eat. And when you have that type of guilt, that comes along with that, those are cycles that are very hard to break. And so we're going to reach women, and if we're going to reach minorities, we're going to have to look at it in a different way.
I didn't understand that.
I've got someboody Siri just answered a question for us.
That was mine. I told you my phone is possessed. It has issues.
Well, I want to empathize with you. My mother, I was an A and B selection as well. My uncle was the pastor, and if there was nobody else sang, I can't sing. So I sang many. I think I'm there, you know, as a lighthearted joke. I probably got a little bit of PTSD from having to do that on more than one occasion growing up in the church. I will say this, that our church mothers and women in our communities are a untapped resource when we deal with mental health. The nurturing effect that our females in the congregations have with men is something that needs to be more accessed. The reason that I say this is because I've worked in the addiction field for a long time, and I've been able to get more through some of our first ladies initiatives, some of our women-led initiatives than I can through some of our men-led initiatives, because sometimes we as men try to be tough to other men. So when a man reaches out to us and asks us a question about our mental health, about our feelings and our emotions, our response is going to be, I'm tougher than you. There's nothing wrong with me. And that is a problem in the communities. And that's another one of those barriers in communication that, you know, we as professional people, hopefully this cohort that Tambi, that you guys have put us on panel with together, I'm hoping that we can do this again, have a separate conversation over some Starbucks 2 hours early so we can get in Starbucks. But I hope that we can have some of these uncomfortable conversations, and maybe we can have some type of strategic approach to contact and connect more in the African-American community, especially here in Davidson County. We have a lot of things that are going on here, and we have a lot of champions that we need to hear their voice. We need to give them a platform to tell their story, because maybe that's how we can get more people to, if they don't access treatment, how about we create more avenues to get them into treatment? How about we figure out more ways to do that?
I said at the beginning of this panel discussion that the idea to have this discussion grew out of conversations among staff members here at the Next Door about how we can move from being an organization that does not discriminate to one that is actively anti-racist. And so the last question that I have for each of you to answer is, what advice would you give the Next Door going forward? What do we need to be thinking about? What are the questions we need to be asking ourselves so that we can be actively anti-racist and provide the best quality of care for our clients, no matter what the color of their skin is? I'd like Ms. Haynes to take a first stab at this.
So I think that what I would say about that has been echoed throughout, you know, this last hour about what can be done. You know, I was thinking about that, and for me, I think that, you know, we're talking about you know, race and addiction, and I think that it is important to center those voices during this time. I think it's important to center the voices of Black people who, you know, have experienced addiction, and you know, and the ones who have not had a really good experience, you know, when it comes to the treatment that they have received, you know, in different programs and those types of things. And, you know, like Mr. Burks was saying, you know, these are the hard conversations that we have to have. And so, you know, it's important that we listen to different perspectives that people have. And just because, you know, it's not your lived experience doesn't mean that it's not true. And so I think, you know, that is something that we definitely need to understand, and we definitely need to respect. And while listening to somebody else's lived experience may be hard for you just to listen to it, just imagine what they dealt with, you know, actually living it and going through it. And so, you know, we can be uncomfortable, you know, just to hear what somebody else has been dealing with, so that we can, you know, move forward in the conversations and to be better with the treatment that we're offering. And then I would also say too, that it's super important that we remember that when people are coming into treatment, you know, they're bringing life experiences with them. And we are all going to be coming from different walks of lives. You have experienced various different things. You know, Dr. Campbell spoke great about, you know, the trauma that people experience. And so I think it's important to recognize that, you know, when you're dealing with people, that people have experienced different levels of trauma, and, you know, and to recognize that, you know, simply Black people have experienced trauma simply because of the color of their skin. And that's a real thing. And to recognize that when you are talking about, you know, the treatment programs and, you know, and the treatment plans that you're going to have for people. And then, you know, Mr. Burks, he talked about it. Language is key. Language matters, you know, and, you know, we can't talk about wanting to, you know, to be an advocate for people that have addictions when we are, you know, using language, you know, calling them addicts and those types of things. And so I think, you know, language is important, you know, when it comes to that. But my biggest thing, you know, in anything, is to center the voices that have those experiences. Let them lead the conversations, you know, during this time, you know, about treatments and again, and just about their experiences, because I think it's really important. Because if we really want to move beyond this, you know, we have to center the voices, because I believe that those of us that are closest to the problem are closest to the solution. And so if we're talking about, you know, race and addiction, then it's the people that have experienced disparities when it has come to treatment are the ones that, you know, we should be listening to, and it should be them, you know, who should be providing the solutions as to, you know, what can be done and the next steps that the Next Door can take. And I don't think that it's really about, you know, being anti-racist. I think it's just really about treating people with the dignity and respect that they deserve. And when you do that, then you will be anti-racist.
Thank you. Thank you. Ms. Campbell, what advice would you give us?
I completely agree with Ms. Haynes. I think it's important to ensure you are aware of preconceived biases you may have regarding race. Be aware of cultural implications on the therapeutic process, and meet the client where she is in the therapeutic process. If you are seeking to serve women of all ethnic and racial backgrounds, ensure you are cultivating a culture of diversity and inclusion within the workplace. So in my opinion, differences are something to be celebrated because we can work together effectively by utilizing our varied perspectives, values, and skill sets to reach a mutual goal. And I agree with what Ms. Haynes mentioned earlier about being respectful and being receptive and really seeking to understand someone's worldview because that's their frame of reference. So I think those things are very essential.
Thank you. Dr. Burks. Oh, you need to unmute yourself.
I would have rather went last. I wanted these powerful panelists have given me some really good food to, you know, go out and, you know, take back to my people. So I'll just say this: the Next Door is a model program. Continue to do what you do. You always make the people that go through your program, the women that come through, feel like there's somebody. You meet them where they are and remind them that they're, you know, that they're still somebody special, that they're always going to be something. There's always something on the other side of it. And also, and I say this to everybody, continue to understand that we're an evolving, it's all an evolving process. Keita said it, Sierra said it, Dr. Graves has said it, that, you know, we've said it in different ways, but we'll say it again. Just because it didn't happen to you doesn't mean it didn't happen to somebody else. So always understand that we are, as professional practitioners, have the opportunity to listen and maybe hear something that a person doesn't even realize is an issue and be able to connect them to resources. I think the Next Door has done that for a long time. So I'm very thankful for you, thankful to you. And I hope that I can be of some service to even everybody else that's a panelist on here. I'm just, you know, God has blessed me to be able to talk to y'all today. God allowed me to live through my addictions, to be able to be a person that even gets to talk today. And I know there's millions of other me's out there. So I hope we can find them and you guys can keep finding them.
Thank you. And Dr. Graves.
I think that the other panelists have said, you know, like great things. And I think it's very important to remember trauma-informed care, but I also think it's important to make no assumptions. I think often we assume that we know where people are coming from and we have no idea. So, you know, often when we see patients who have substance use disorder, they are at their lowest, but we don't know where they've come from. They could have been at their highest. So we definitely need to make sure that we make no assumptions about who they are as people, what their life perspectives are, where they've come from, and how they've gotten to where they are. We should listen to everyone's story and respect it for what it is. And like someone said, just because it doesn't happen to you doesn't mean it doesn't happen to others. The other thing is something that's been really bothering me in this season is people say, I don't see color. Well, unless you're blind, you do. And so therefore, it is important to factor in. You know, one of the things we've been doing in pregnancy is when I look at a pregnant risk assessment for stillbirth and poor pregnancy outcome, I factor into the fact that someone's African American. And I had a patient just the other day who was 41, who wanted to go home, whose blood pressure was a little high. And I said, oh no, you're in the high risk group. Said, not only are you over 40, but you're African American, you're in the group of people who are more likely to have poor outcomes. And so we have to factor that in. If we're going to have success and truly be anti-racist in taking care of the patients that we've been entrusted to care for. And I've worked with the Next Door for a long time. Actually, for those of you who don't know, was one of the founding board members of the Next Door, way back with Barbara Engelhardt and some other people who thought it was time for us to have a place in this city where families could go, because substance misuse is a family problem. It's not a personal problem. So when you have children, it truly becomes a family problem. And we're just so thankful that you're here. And we look forward to working with you to expand the services, the great work you're already doing, the services you already offer.
Thank you very much. I see that we've had one question come into chat and we've got a couple minutes left if there's any others that anyone would like to submit. The question from Tess says, since many justice-involved individuals do not have access to health care, I'm curious if you guys are hearing of any new funding being dedicated to justice-involved individuals to seek treatment, either post-release or as a diversion tactic by judges. Are any of our panelists aware?
What was the question again?
It's a, since many justice involved individuals don't have access to health care, are there any new funding sources dedicated to justice involved individuals to seek treatment, either post-release or as a diversion tactic?
I don't think post-release, no. And particularly, you know, anybody that has served any type of jail time or prison time, you know, particularly if it's prison time, that's going to be, it may be up to the Board of Probation and Parole if they are paroled. But a lot of times what happens with people is that once they are released, they are released. And that's it. There are no wraparound services in the communities for, you know, people. You know, there may be something where people have to, you know, do a 45-day drug program in jail, you know, just to get out. And then they do that 45-day program in jail and then they get out, and that's it. As far as, you know, judges, I mean, you know, there's the drug court program that Jennifer Smith oversees. And that's in criminal court. And then there is, you know, Judge Robinson, who oversees criminal drug court in general sessions. And I see Lauren's on the call, and I know she worked in general sessions. And I worked in Jennifer Smith's courtroom when I was at the public defender's office. And, you know, she took over for Judge Norman and has done a really good job, you know, with the women when it comes to drug treatment, and you know, and you know, the men in the program as well too. But I think, you know, again, you know, my problem with all of this is that, you know, we're criminalizing addiction. And so, you know, I think, like, you know, what we're not taking into account is that, you know, in a lot of these situations, people are pleading guilty, and in particular, if you're going to drug court and criminal court, you're pleading guilty to a felony. And there are just a host of collateral consequences that come, you know what I'm saying, with a conviction. And, you know, and not understanding that, you know, when you complete this program, you know, you still may have problems, you know, getting a job, may have problems, you know, getting housing, you know, being able to go to school, you know, all of those types of things, because those are collateral consequences that come along, you know, with pleading guilty, you know, whether it's a misdemeanor, and, you know, and particularly felonies. And so, you know, that's one of the things that I don't think that we talk about, you know, and that people are really aware of when we're talking about, you know, criminalizing addiction. And so I think that, you know, my personal thoughts is that addiction should be handled outside of the criminal justice system. You know, we should not be handling anything related to mental health or addiction in the criminal justice system. And I think that that's where a lot of times the stigma comes from as well too, because of the way that it's handled in our society. And I think that, you know, we cannot start talking about, you know, how we can get people coming into treatment and, you know, and all of these types of things until we really talk about removing the stigma and really decriminalizing addiction and mental health.
Well, it is time for us to wrap up. I am deeply grateful to our 4 panelists for devoting time to us today to talk about this important issue. I have taken a lot of notes personally. This has been very helpful and challenging for me, and I know that our discussion will help to guide further discussions here at the Next Door. I offer blessings upon all of your areas of work, panelists, Ms. Campbell, Ms. Haynes, Dr. Graves, and Dr. Burks. Thanks again. And to all of you who joined us for this discussion, I hope you have a lovely rest of the day. Thank you for being with us at the Next Door today.
Thank you so much for having us.
Goodbye.
Bye, y'all. Keita, Sierah, Dr. Graves.
Yeah, thank you for having me.
Bye. Thank you so much.
You're welcome.